Everyone. My name is Cami Keogh. I'm a registered nurse in Ely, Nevada, and I am completing the RN to BSN program at Great Basin College, and this is my fall 2024 quality improvement project. So the summary of my quality improvement project is to improve the nursing staff's reporting and documenting of patients' critical laboratory values obtained at William B. Ryrie Hospital. So here is my PICO question. So the problem is that 20 to 50% of critical value results are mismanaged in one fashion or another. I'll further get into this on the next slide, how they're mismanaged. So my intervention is to provide and initiate a quality improvement plan that will eliminate mismanaged critical values through nursing staff education. My comparison is include within the QI plan a method to maintain data for critical values evaluation, such as a Meditech special line item, which I'll explain later what that is, and an Excel spreadsheet that I have also been keeping track of with CNO Pamela Adzema. My outcome is to provide safe and timely patient care by eliminating issues such as non-RN staff members acquiring the critical values from the lab. And time is evaluation and re-evaluation of the critical values QI program monthly with risk management team and quarterly with the hospital nursing staff. So more details on the problem, like I said earlier in the PICO slide. So there's a few issues going on with the critical values at William B. Ryrie Hospital. So one of them is breach of scope. So nurse apprentices, CNAs, and ED techs are not to receive critical values. This is within the scope of the RNs and the MDs only. Bad data. So bad data meaning the RN name that the lab technician records has not always matched up with the RNs on shift. So let's say the lab tech reports that Kelsey took the critical lab value. Kelsey wasn't even at work that day. So that's an issue. Lack of documentation also. So the critical value is being received by the registered nurse, but there's no documentation of them passing that on to the MD. And so how are we to know that the MD ever even received that critical value? So there's a few issues going on with this, as you can see. Standards of care with critical value reporting. I looked at the Center for Disease Control and Prevention website, and from there I looked at the Joint Commission and the National Patient Safety Goals of 2025. So according to evidence-based practice obtained from the Center of Disease Control and Prevention, quote, rapid communication regarding critical test results is a 2025 National Patient Safety Goal. These are decided upon by the Joint Commission. However, it is listed under the laboratory program rather than the hospital program. Something else, I did not put it in my notes here, but I found it interesting. I could not find a specific time interval on the CDC or on the Joint Commission for critical value reporting to the RN or the MD. However, it does say that hospital policy has to have a specific time interval from when that critical value is received from the lab to the RN or the MD, but it does not specify the time limit. So I thought that was interesting. quick review of the current policy at William B. Ryrie Hospital, which is my organization. I won't bore you with all of the details, but in summary, if this nurse receives the results, they will notify the physician as soon as possible, but within an hour, which is actually pretty liberal. According to my research, most policies state that these numbers need to be reported within 15 minutes. So the physician notification will be documented in the electronic medical record. So that is part of our policy, and that is not happening 100% of the time. We'll go over the specifics of the data shortly. And this doesn't really apply to med-surg, but I put it in here anyways. So outpatient critical results after 7 p.m. and prior to 7 a.m. will be given to the ED provider on duty, and timeliness of critical test reporting will be part of William B. Ryrie's organizational improvement program. Each department can set their own indicators, but it's just hospital-wide. 1 hour is the maximum limit. Go over really quick the fall data review with you guys. I've been collecting this information and reviewing it with the Chief of Nursing Staff, Pamela Adzema, once every few weeks. So in September, the number of critical value events was 33. The average time that the MD was notified was 6 minutes. Number of events reported by the lab to incorrect personnel, so not within their scope to be receiving those figures. There were 7 incidents, and number of events with no documentation of reporting to the MD at all. So that was 5. So did the MD ever get the results? Was it just not charted? So we're a little non-compliant there as well. Same thing in October. However, October was a heavier month for critical values. So there were 59 events. 9 minutes was the average time from RN to reporting to MD. The number of events reported by or to incorrect personnel were 4. And I found this interesting too. The number of events lab documented an RN receiver that wasn't on shift, that happened twice. So I think there was probably some guessing going on as to who they even reported to. And they just so happened to pick 2 nurses that weren't even on the schedule that day. And the number of events with no documentation of reporting to the MD at all was 11 in October. November 2024, there were 46 critical value events. Reported to incorrect personnel was 2, so that number is getting a little better at least. I think that people just needed some remediation on that. So average time the MD was notified was 5 minutes. Number of events with no documentation of reporting to the MD was 8 minutes. So it's important to realize, depending on these numbers, if the critical value is being mismanaged, that average time duration goes up or down. So it could actually be better or worse depending on the number of critical values being documented. Because if it's not documented that it wasn't received by the MD from the nurse, then we can't count that in our metrics, unfortunately. So documentation is really important. So this is just a graph that I made kind of showing all of the figures that we just went over through fall of 2024 for the critical value analysis. So in summary, anywhere between 20 to 50% of critical value results are mismanaged in one fashion or another. Time the RN reports critical values to the MD is well within the policy specified hour to report. So we're doing good with that. So conclusively, RN to MD reporting is in fact not the issue, which is a good thing. So some potential tools and systems to help with the critical values quality improvement plan is, of course, good data collection. So the Meditech specific line item that I mentioned earlier, there has been a line item created and added to the Meditech EMR. It's called our work list. So, critical value reporting is the line item on the work list that the RNs are supposed to chart all of the information received and passed on to the MD. And then Microsoft Excel is what Pam Adzema and I have been using to track that. And it is acceptable to make a nurse note of the critical value received, but the problem with that is if this critical values reporting form is not used by the nurse and they just do a nurse note, then unfortunately not all of the information needed is captured all the time in a freehand note. So it's best to use the critical value reporting line item. HealthStream for annual online learning competencies. It's my understanding that you can get, or you as in a nurse leader can get a hold of your HealthStream rep and they can create a module and add that to the annual competencies work list. We do a semi-annual skills and drills day. Um, it's basically like simulation that we did in school, but it's just done during work. We do it a few times a year. So training on this critical values quality improvement plan could be rolled out during Skills and Drills Day. We could just have a workstation for critical value handling. And consistent interdepartmental communication is huge. So laboratory, administration, nursing, and physician services are the main, the key players involved with managing these really important numbers. So I selected the DMAIC method. I figured this would be best for rolling out this plan. So I'll just go through really quick, define what measures and indicate success, 100% RN documentation of critical values reported to RNs, and 100% reporting of the critical value to the physician within the policies defined timeline. So we're pretty much on track with that, other than a few people who are not supposed to be receiving the values. Measure baseline performance. The CNO has shared this spreadsheet with me. She's manually collecting the data and routinely reviewing it with me. Analyzing results, explore positive and negative changes. An example of this may be one group of RNs may be properly documenting and reporting, while others may need remedial training. Improve performance, communicate with organizations, RN staff regarding the importance and concern of performance measures in terms of mishandling patients' critical values, and discuss with staff potential avenues that will lead to improvement. And control and sustain performance is the last part of this method. So share wins with your team. That's a big part of the nurse leader's role. So such as trended improvements as the data is tracked. Incorporate critical value training into annual competencies for the RN staff. And lastly, the nurse leader's role and responsibility in the QI plan. So participate as an involved member of the risk management team, keeping them up to date with how things are going, if they're improving, if they're not improving, planning and implementing of the QI project, because this seems to be a nursing staff issue. I think it's a little bit of a laboratory staff issue as well, but it's certainly a nursing staff issue too. Obviously, your chief of staff or your nurse leader would be highly involved in implementing the project. monitoring the compliance for nursing staff annual competencies, like I said, health stream modules, semi-annual skills and drills days. And the skills and drills days, they're not just for fun. They are fun, but they are part of our annual competency. And so it is important that we participate in those and that we take it serious. Bridge communication gaps between departments while harboring respectful and professional relationships with other managers. So Pam once told me during one of my visits with her this semester that good good leaders build bridges. So basically what she meant by that is while it is important to support your staff and to have their backs, it's also important to see the other department or the other person's perspective and to maybe be open-minded as far as realizing that sometimes like your own department may in fact be the issue, and it's okay to own that. Like, we're professionals and that's what we do. We own our mistakes, and that's how we learn. And then reevaluate policies and processes that support patients as well as nursing staff. So that is my quality improvement project. I hope that you guys enjoyed it, and I hope that you all had a great semester. And here is my reference page. Thank you.